And it is my pleasure to introduce Dr. Ken Maddox, who, of course, needs no introduction. Dr. Maddox has been a fixture and an icon in American trauma for years and years and years. He's the chief of surgery, chief of staff down at Baylor in Texas. He has authored innumerable hundreds and hundreds of articles. He is well known for his textbook, co-authoring of trauma, also known for his book, Top Knife, which still gets good play. And Ken, both of my fellows, I want you to know, were reading it in their call rooms the other day. Dr. Maddox, in addition to being a master surgeon, is also a master often of unconventional thinking. And I think he's led us to reconsider a lot of our traditional approaches to problems and has pushed us along in directions we might not otherwise have gone. Dr. Maddox is trained broadly, he operates broadly, and is truly a master surgeon. Please welcome Dr. Ken Maddox to the podium.
Thank you very much. Could you put my slide? Thank you. Dr. McCursey, ladies and gentlemen, I am honored and delighted to be able to present this Master Surgeon lecture and to hold this first talk on this day, on Friday, the next to the last day of this meeting. It is an humbling task to try to summarize the work of so many people that are in this room and in this organization over the last several years, and to focus on what is the exact role of the acute care surgeon in vascular trauma today and in the future. It is our responsibility to, from a quality standpoint, look at what opportunities, what personnel, what exists today in technology, and how that can be applied, and what is our exact role in fulfilling that responsibility to our patients. I'll try to accomplish that in the next 20 minutes or so. The last 50 years or so have been an absolutely incredible, wonderful era. It's been a great era for medicine, and it's been a great era for members of this organization, and especially for me. It is overlapping specialties. If you think about it a moment, vascular, cardiac, general surgery, trauma, emergency medicine, surgical critical care, all have developed at the same time. As they initially began, there were tremendous experimental, clinical, technical advances, and even before the emergence of IRBs, advances were made, also sometimes not so good advances. I must tell you, I have no disclosures except my training with individuals who did not know the difference between these groups, trained a group of surgeons during this era who called themselves only surgeons. As a result, I was eligible for 6 different boards to be credentialed in. My disclosure is, for political reasons and personal reasons, I chose only to take the boards in 2 of those specialties. However, these specialties are interlinking and in many ways pertain to the message that I wish to leave for you today. Vascular frequency harmonics repeatedly tell us, we repeatedly hear the words, what has happened and why must we always have to return to the lessons of the past. I've heard such comments from Dr. DeBakey, Dr. Rich, Dr. Rasmussen, and many of you in this audience. Civilian vascular trauma at the beginning of this era had no vascular surgery boards. Vascular and general surgery were the same. there were very few GME sites in vascular surgery, very few hospital centers of excellence in trauma, vascular surgery. Prosthetic grafts were limited, vascular suture was limited, plastic was just beginning, and spring clamps and instrumentation and imaging was totally different than it is today. I've had the opportunity at Baylor to work with those individuals and to be trained by those individuals who only saw themselves as a surgeon, an overall surgeon, an acute care surgeon, an emergency surgeon, and peripheral vascular surgical techniques, truncal vascular surgery techniques, EMS studies, transvascular tricks, and catheter techniques for surgical dummies has all been part of that legacy. But it's today that we are focusing on. And today, as you heard yesterday in the presidential address, Dr. McKersey, is that the major cause of death is hemorrhage and lack of control of that hemorrhage. There is now a mystery of vascular trauma, a mystery both by general surgeons, single organ surgeons, and many of the basic principles are no longer taught or understood. There's a significant military medical issues that I will talk about later, and there are manpower challenges I will talk about later. But reflecting on this problem, the question comes, how did we get here? We got here through a series of epiphanies, and I will focus on those epiphanies on the next 10 minutes or so. Starting back 2600 BC, the first of these is the Edwin Smith surgical papyrus, probably written by Ein Hopfid, architect, physician, who was the author of the Edwin Smith surgical papyrus, probably. Liberal use of packs, caustic, and suture, and in this document, to stop hemorrhage, to slow hemorrhage, is used in a number of places. By 1258 AD, another epiphany occurred in the person of Ibn Nafis, originally born in the Syria, Iraqi area, and then settled later in Egypt. Nafis described pulse, coronary circulation, 3 stages of an operation, capillary circulation, and he described, as we now know from the last 25 years of translations, the central circulation 350 years before William Harvey. His epiphanies are such that if you read his writings and Harvey's writings, some of the words, sentence structure, are absolutely almost identical. Ibn Nafis' drawings are here, his words are here, and that was an epiphany. 1597, another epiphany occurred in the literature in the form of William Shakespeare. In Shakespeare's Merchant of Venice, Portia uses the word to Shylock, the attorney, to stop his wounds lest he do bleed to death, a comment heard multiple times yesterday and even today in this conference and faces us all along. In 1884, 129 years ago, an epiphany occurred in France. In June of this year, the French President Carnot was assassinated by an Italian archivist, had a stab wound to the abdomen. His only injury was a severed portal vein. Alexis Carrel, an intern at the Red Cross Hospital, observed that autopsy and said, after that observation, there has to be a better way. In 1905, Carrel, at the age 31, with Charles Guthrie, developed the technique of triangulation for venous vascular anastomosis at the University of Chicago, and just a few years after that, was awarded at age 38 the Nobel Prize in Medicine for this work. There always is a better way. The wars, great wars of this century created epiphanies, and analysis of those wars give us significant information. The British recollection of vascular injuries is the greatest that we have from World War I, indicating that the majority of the injuries were in the extremity, forearm and the legs, with a significant amputation rate, and 5 aortic injuries, all of whom died. You will notice 128 carotid and vertebral injuries. The recommendations from that paper are that ligation is the most common treatment. Suture repair in 29 cases. Suture was recommended as par excellence, but logistics and time required prevented this method. The data mixes acute injuries and delayed traumatic aneurysms, so it's sometimes difficult to analyze. Dr. DeBakey had the largest series out of the Second World War and indicated that the arterial injuries are a small portion of the overall war wounds. You will notice again the predominance of extremity injuries, 3 aortic injuries, 2 of whom died, and amputation rates that, especially in the leg, are quite high. Ligation was the most common treatment. Concomitant vein injury was studied. The 81 suture repairs did occur. 40 vein grafts were done with a 57% amputation rate, and 14 tube grafts, all metal, 50% occupation occurred. Even at that war, temporary intravascular stents were used, glass, silver, titanium, magnesium, which was also advocated by Jaeger in 1913. The double tube vein graft was proposed, and none of these had any statistical advantage. After the Second World War, because of the data you've seen, it was recommended that in future world wars, ligation be the principal form of treatment of vascular injuries. Dr. DeBakey's paper recommend anticoagulants, fasciotomy, refrigeration, oxygen therapy, posture, and ironically, sympathectomy and nerve blocks compose a significant portion of that paper. In 1953, while a sophomore in high school, I had my first epiphany as it relates to this subject. My biology teacher and my geometry teacher caused those epiphanies. In biology, I learned that the taxonomy produces order, and that order produces the ability to classify, and the ability to classify is the ability to analyze. In geometry, I learned about the Pythagorean theorem, and I'll not ask any of us to repeat that, but from that I learned that there is a scientific method that is evidence-based that we can use to then prove other theorems. I was so excited in learning and solving those various theorems. That same year, Frank Spencer went to Korea and had an epiphany. And Frank Spencer told me that he was told to ligate wounded vessels, but he couldn't just allow them to be ligated. So he violated orders and began to repair. And he and Carl Hughes began to analyze their results. With comments made in those papers, why must we always have to relearn the lessons of the past with those frequency harmonics continuing? And the incidence among casualty is unknown, but the injuries are described here with, again, over 90% being in the extremities, particularly the lower extremities. Ligation had a 51% mortality, and other treatments had a lower, amputation had a lower amputation rate. 64% of those injuries also had venous injuries. There always, ladies and gentlemen, is room for improvement. There should be continuous improvement. 10 years later, I was a junior in medical school at Baylor College of Medicine. On a November in 1963, I had another epiphany. Remember where I was. I was in Houston, Texas, where as many as 75 cardiovascular operations were done every day, and it was just commonplace, more common than anything else. At that time, Lee Harvey Oswald was shot in the abdomen with simple injuries to the aorta, superior mesenteric artery, and inferior vena cava. My reaction as I watched that on television was, these injuries are only to blood vessels. They're sewn together every day in the Texas Medical Center. It must not be that difficult. The naivete of a junior medical student who doesn't know any better. At that point, I said there's got to be a better way to expose the suprarenal abdominal aorta, and began to read about various exposures. And I was amazed to find how primitive we were at that time. That same year, Major Norman Rich began the Vietnam Vascular Registry and began to put together data. Notice again that over 90% of the injuries were in the extremity. There were over 8,000 people in that vascular registry. The 1,000 were reported in the greatest detail. The methods of reconstruction now were greater than ligation, occurring now in only 1.5%. Some prostheses were used. Vein graft was a principal cause, a method of reconstruction. The mortality rate was of those arriving for repair was 1.7%. Dr. Rich recommended vascular surgery trauma is here to stay. We need to know in more detail than previously, and we need a vascular trauma data bank, and trauma registries are essential. There's always room for innovation. In August 11th, 1970, when I was a fourth-year resident, I had another epiphany. That epiphany is recorded here in the drawing and an operative note from that operation. I had a patient with 3 previous stab wounds to the abdomen, now with a gunshot wound inflicted by the same girlfriend that inflicted 2 of the previous stab wounds. There's obviously a lesson there. And we could not get to the retroperitoneal hematoma, and as a fourth-year resident with no chief resident in the room, no faculty in the room, my first assistant being a urology resident, we figured out a different way to get to the aorta. This patient survived, as did several others that were reported later at this organization. And that medial rotation of the viscera became a standard operation, even though one would lose up to 6 units of blood in performing this maneuver. There is always room for new approaches for the individual who is well prepared with an understanding of anatomy, technique, and the tools you have to do so. But during those times, even then, the frequency harmonics of saying, why must we continuously have to be relearning the lessons of the past? Between 1965 and 1980, epiphanies occurred in the general, emergency, acute care surgeons in multiple hospitals across the United States. Many of those individuals are sitting in this room. And the results of these treatments were often reported at this organization and in the Journal of Trauma, and often no other place. These general acute care emergency surgeons changed the face of vascular surgery, and regardless of what they were called at the time, it has a historic role in vascular trauma, one that this organization can be very proud of. There is always room for leadership. These eager general surgeons were frequently residents, many veterans of Vietnam, and often presented here. I can remember those days when we fought each other to be on call in order to get the big bad case. We wanted the big bad case, the one that bled the most. We did not want the simple, straightforward cases. It was in our genome. It was in our motivation. We love to be a master surgeon or want to be a master surgeon. And in those days, many of these individuals became some of the most adept, technically expert surgeons in the world. Again, many of those people are in this room at this very moment. We learned on the first day of this meeting that over the history of this organization, that resulted in 4.2% of the papers presented here. I found that to be a relatively small number. We're in the area of controlling of hemorrhage. The next several slides are merely the advances in that treatment of various vascular injuries that were reported here during those eras. Early in those, and initially I was going to put what the treatments were at the beginning of this era and the end, but time did not allow me to share all of that. Late in the 1960s, there was one paper on subclavian artery injuries that described 12 different approaches to that particular injury, and all of them were very confusing, including most of those being totally abandoned at that time. We now, many in this room, are using other techniques for complete transections of subclavian arteries with wires put in from below and above, using routine garden variety C-arms in the operating room that's available in every operating room in the world, using a grabber to pull the wire down, slide a graft over it, and in 20 minutes you're done and go on to the next case. Very simple. Done by Dr. Matthew Wall, who's in this audience, on a regular basis for the last 3 to 4 years, and teaching that to general surgery, acute care emergency surgeons is now a matter of ease. In the operating room, arteriograms done by the surgeon for a variety of reasons. The various approaches to various arteries was a very exciting time where operations were limited. Occlusive techniques were proposed very early. More on that later. These techniques became very standard and are in now the standard textbooks, and I don't need to spend more time on that. By 1980, trauma surgeons had pretty much worked out standard approaches to vascular trauma, and outcomes were established. I'll share with you a few of those outcomes here. Emergency center thoracotomy had greater than 90% mortality rate. Abdominal aortic injuries were 60% plus among those centers reporting. There were then, and there are now, trauma centers represented by individuals in this audience that have never, ever, never, ever, ever had a survivor from an abdominal aortic injury. Inferior vena cava, iliac artery, portal vein, and combined injuries were at that time in 1980 rather high. Between 1995 and 2013, there was an epiphany in vascular surgery circles. Vascular retooled their own approaches. Endovascular technology occurred, little to no trauma training, often slow to respond to night call. It is stated that vascular surgeons and interventional radiologists buy some weird international car that is devoid of headlights and have the inability to come in at night. There were tremendous increase in cost and not necessarily increases in outcomes. There is room for new technology, and that new technology is not rocket science. That new technology has a capital perception that goes into the hundreds of millions of dollars at times with all sorts of bells and whistles. It is often driven by industry. The endovascular basics are no different than the open basics. Clamp, cut, sew, tie are the principles listed in the Edwin Smith Surgical Papyrus, the oldest medical textbook known to mankind. It is relatively simple. those tools, those toys, those instruments are simpler than the instruments we use every day for laparoscopic appendectomy and laparoscopic cholecystectomy. And individual surgeons choose different introducers, sheaths, wires, and catheters to be their preference, just as individual surgeons in this room have their favorite vascular clamp. The surgical needs should dictate technology. Technology and industry should not drive surgery and medical practice. In vascular surgery, the bottom line tends to drive what is done in many hospitals. The irony is that general surgery in the 1970s and 80s ran to minimally invasive surgery. General surgery today is running away from vascular surgery. General surgeons in laparoscopic surgery, I've listed here, changed the face of surgery because they had the courage and the desire to master this field that was more complex than anything done by interventional radiology or vascular surgery today. Meanwhile, new major wars were being waged and 6 different databases were developing. So the next epiphany occurred with the Iraq and the Afghanistan wars. We were relearning lessons of the past. Again, frequency harmonics. During the Iraqi-Afghanistan wars, the FST was formed. Many of you participated. The Joint Trauma Training Centers and databases and registry, hypotensive resuscitation, vascular stents, one-to-one-to-one, and many others. The in-flight care, the SICU, the centers at Lonsdale, Walter Reed, San Antonio produced tremendous results in especially extremity injuries. The capital reality is the capital reality of every operating room in the world. Rather than the multi-hundreds of millions of dollars expenditure, simple orthopedic C-arms with simple catheters, wires, and devices were available there and are available in your hospital right now. Comparing the wars to the National Trauma Database, you will notice that the injury percentage is almost identical except in thoracic aorta, which is more predominant in civilian practice for the blunt deceleration injuries. Otherwise, the percentages are the same. I've listed aortic and iliac together because the mortality rate of those injuries, both in military and civilian experience, is almost the same. Although in the military, there were no aortic injuries reported in the latest reports by Dr. Rasmussen. So here we are today. Lots of talk, very little action. And there is the epiphany of discovery that occurs now, real time. It's a product of frequency harmonics. It reminds me of the discovery that occurred in Apollo 13. You'll remember that message from space. Houston, we have a problem. Problems result in trouble. Trouble, trouble, trouble right here in River City. That begins with T and it ends in E and it rhymes with U. That problem is the educational and technical changes have caused these problems. The root cause lets us then have a root reduction strategy. That perfect storm produces disasters. Those disasters remind us again that we have to relearn repeatedly those lessons of the past. And we ought not to create new problems. That root cause is in many areas. Vascular trauma crises during the 2000s, trainee work hours restriction, regardless of where it came from, it has resulted in many issues that you have debated. It's produced the single organ surgeon, focused practices, and the general surgeon, thoracic surgeon, vascular surgeon, tri-trained individual has totally disappeared. The general surgeon has had a decreased training. There is vascular surgery is principally an endo training. Vascular surgery graduate medical education has changed so that you can go right into vascular surgery, not ever learning how to tie knots or pronate or supinate. And there's decreased trauma for all of these individuals. The general surgery trainees of the 2000s have a significant reduction, Dr. Lewis, in their vascular surgery requirement. Amputations, AV fistulas, vascular access account for the majority of individuals applying for the American Board of Surgery. There is no vascular life-threatening experience by most trainees that are completing general surgery today. The vascular surgery trainee has almost no vascular trauma experience. They have moved away from open procedures. As a matter of fact, they are scared to death of those individuals trained recently in vascular surgery of open neck, chest, abdomen, and groin. The trainings have changed as well. Thoracic surgery trainees have no peripheral vascular training, no trauma training, and they have become single organ surgeons in the chest and no endotherapy training at all. Been there, done that, seen the data before, but they do bleed to death. So I share with you this slide I've shared with you earlier. I'll let you focus on the percentages and bring you up to date. We can, should, and must do better. During this period of time of somewhat 33 years, we virtually have not made any change. Those centers that were doing poorly in aortic injuries are still doing poorly in aortic injuries. The current military vascular trauma challenges today, there are only 15 vascular surgeons in all Department of Defense assignments. A number of those in command assignments where no clinical exposure occurs. We now know that the leading cause of preventable death in the military is hemorrhage from vascular trauma, the inability to control and resuscitate. And there's fear of vascular surgery, vascular trauma by the acute care surgeons who are in the DOD, be they reservists or be they volunteers or be they drafted. Ladies and gentlemen, count them. Dr. McCursey, count them, 15. Dr. Rasmussen, count them, 15. Dr. Rich, count them, 15. Dr. Woodson, count them, 15. President Obama, count them, 15. There is no bench. Where, if we went to war tomorrow, wherever we would go, who is going to care for the wounded warrior? The current civilian vascular trauma challenges continue. I've already underscored the limited vascular training. 80 to 90% of trauma-preventable deaths are from hemorrhage. 80 to 90% of the current trauma surgeons existing in North America are uncomfortable in managing hemorrhage control and repair. Sobering. You've heard already at this conference, you'll hear again today and tomorrow about resuscitative endovascular balloon occlusion of the aorta. This is a 16-hour, 2-day course, inadequate to get certification, but certainly beginning. Here, a drawing which came from way back in the 1960s and 70s, a concept which was discussed and recommended by Alex Walt and myself at the time of the 1975 aortic trauma to this organization that I shared with you earlier. We actually made some of these balloons, and I will tell you, in this audience. Matthew Wall put some of those in the very early days. This was 38 years ago. Just what is the problem? The problem in contemporary vascular surgery is we have a capability gap. Remember I told you earlier that master surgeons, who were the best of the best technically anywhere in the world in the 1960s to the 1980s, constructed this field we're talking about, and they were in this organization. We called them just surgeons back then. That capability gap has resulted in frequency harmonics, often overlapping, often neutralizing, which has resulted in forgotten and ignored lessons of the past, neutralizing technical progress, and competitive educational agendas, often controlled by local politics. There is a need for a new change. So in September 20th, 2013, there is a time for an epiphany. That epiphany is to this organization for emergency acute care trauma surgeons to hear the challenge that you've seen on these slides. There's we have a historic role, virtually the only historic role in vascular trauma and advancing that. That role in the future, Dr. McCursey, is to serve in one or more or all of these capabilities. As a vascular gatekeeper, the individuals in this room, through very simple technology, can insert a balloon, can put in a sheath, can prepare locally for that vascular surgeon who may come and participate together. We can own the field of vascular trauma. Quite honestly, I believe that in this audience, all arteriography, all embolization should be done in the operating room by us, completely, with existing, very reasonably priced equipment available in every operating room in the world. It is now being done, ladies and gentlemen, by surgeons in Mexico, Brazil, Colombia, Thailand, and a relatively meager few in this audience. Own the field of vascular surgery emergencies, including ruptured abdominal aortic aneurysms, et cetera, et cetera, et cetera. Take the courses, master that technology. I am here today to say that blood loss can be remarkably reduced by this technology. As of today, although I did this procedure as short a time as last Sunday, medial visceral rotation to expose the aorta or modification needs to stop. An endograft inserted over a wire, over this balloon, is extremely simple. Visceral bypass if necessary, and numerous other innovations. Finally, Dr. McCursey, ladies and gentlemen, I leave you with a challenge from the past, because there is always room at the top. In the Prince, Machiavelli has said, there is nothing more difficult to take in hand, nor more perilous to conduct, nor uncertain in its success, than to have the courage to fail and take the lead in the introduction or reintroduction in a order of things. For the innovator has for enemies all of those who have done well under the old, and lukewarm defenders in those wimps who wait to see which way the wind is blowing before they decide which way they're going to go. Dr. McCursey, this audience is not made up of wimps. There are individuals here who have the courage to fail, who recognize a challenge, and who recognize when there is a void, when there is no bench, and to move forward. I have a clear vision. I have a clear vision of 500 papers coming out of this audience in the next few years, presented here and elsewhere, on innovations for the acute care emergency trauma surgeon who is there for the future. It will give life to the possible. After all, it is our legacy, it is our genome, and it is our epiphany. Thank you much for letting me share with you this review.